Hello. Hello, everyone. Uh, can you guys hear me? We shall be starting the session shortly. And today we have a new beginning. Basically, after doing physiology, it is very logical that we shall be starting with pharmacology. After doing everything like organ-wise, जो भी हमने different physiological systems हमने पढ़े हैं, and now we'll be putting them into actual clinical practice, and we shall be going over pharmacology from the next maybe 10 days. We'll try to finish pharmacology up. So we have started it on with a very important unit, which I think is even before studying your general pharmacology, it is better that we study rest of the pharmacology beforehand, right? Especially when we consider like many of the drugs which are mentioned in general pharmacology are not basically known to us before we start the rest of pharmacology. So it will be my advice personally that even if you read general pharmacology for once, it's fine. But I think जो आपको maximum efficiency है or the maximum thing that you will get out of those chapters will be only after you have done the rest of pharmacology. ठीक है? And that is was the case for me. ठीक है? So आज से we are going to have two sessions on ANS pharmacology because we have already talked in great detail. Actually, we had skipped autonomic nervous system, and I was doing that purposefully because I thought कि ANS pharmacology में we can cover the autonomic nervous system as well, which was left in your CNS. That is in CNS physiology. So I've already shared the notes with you on the Telegram group, so you can watch out for that, and you can annotate along with me as well. If I'm audible, please give me a response, and we shall be starting at 10 p.m. exactly. Thank you everyone for joining. Thank you so much, Sanjay. So in a while, at about 10, we shall be commencing this session. Today I have 60 slides for you. I think, thank you so much, Shmangi. Today I have 60 slides for you for ANS pharmacology. That's in part 1. And today we'll be basically looking over the cholinergic drugs as well as the anticholinergic drugs. Okay? And we'll also take up the ANS general considerations. So all of the stuff that I've made for pharmacology, just like guys, I told you, ki physiology ke liye I have referred to Ganong and whatever we are having these sessions for, because I think that is the standard book that we should be referring for a NEET PG or FMGE or any other examinations for say. So in case of pharmacology, for me, it is mainly KDT. I can even suggest you guys to go for Kadzing as well, because Kadzing has the conceptual part that is given very beautifully in Kadzing, which might be lacking in some aspects in case of KDT, at least for some chapters. For example, if I remember, anti-rhythmics I understood very well when I read it from Kadzing. Okay? Especially the CVS physiology, CVS pharmacology is given very well in Kadzing. But the antimicrobials part, obviously, that is way more advanced in case of your KDT. So both of the books have their own pros and cons. But all in all, for your university examinations, I would still go for your KDT. We have other books as well for pharmacology. This is for second year people. Many of them have been starting to follow your Shanbag, but I would not suggest that, especially when you're just beginning to understand pharmacology and you're having your first read. I would highly recommend that you study from a standard book, that is your either KDT or Kadzin, but not from Shanbag from the onset. Okay, that is more of a review book after you have done all of the chapters from your KDT, after you have made your notes. And I highly suggest that you make notes for pharmacology because it's a big topic. As we are transitioning from your first year to your second year, things are going to get tougher this year. Okay, and you guys even have lesser amount of time that we did. We almost had 1.5 years to study your second year, but that seems to be lacking. At least you have a one subject is off, right? So FMT will go into your third year, so that's a relief. uh, but mainly I would highly suggest that you make a foundation this year. This year is super duper important for you guys. and I think you'll be doing really well if you study every day, at least 2 hours every day, 2 to 3 hours every day. I think that's a good amount of time that you can put in, and stay, and do not skip your clinics as well. Okay, so I think many people have joined. Let me just wait for 1 more minute, and then we'll be starting shortly. Okay, so my message to all of you, especially in second year students, are that you follow your KDT for the time being. Later on, you can transition to your Shanbag in case of your examination. But I think examinations it would be like notes from KDT that you have made on your own, as well as your Shanbag if you want. If I didn't refer to it, I didn't find it uh, useful, but I think you people can. I've seen the book; it's good. But for the conceptual part, it's always KDT which I need you to go for. And even in case of your Viva examinations, if you blurt out something from Shanbag, the problem that arises is whenever we give a explanation for whatever the mechanism of action of a drug is, the next follow-up question जो होता है ना, that is very difficult for us if we have only read Shanbag. The first question you'll definitely crack, ठीक है? But the next question and that will come that goes into some more detail, वो आपको थोड़ा miss out हो जाएगा. All right. So I think we have quite enough people who have joined today. I thank you very much for joining. So today, let me just start with this session, okay? All right. So we are on ANS Pharmacology. So first, आज we'll be talking about your cholinergic and your anticholinergic drugs. Okay, let me get on to it. So we know that the central nervous system is mainly based on somatic nervous system, and then you have your autonomic nervous system. When I mean by the somatic nervous system, that is under our own voluntary control. For example, just remember, जो भी हमारा motor neuron है, I think it would be an alpha motor neuron, right? At the ventral horn of the spinal cord, you have the alpha motor neuron. All of these fibers are mainly myelinated fibers. That is why I call them as A alpha fibers, right? So the A alpha fibers, we know they're myelinated motor neurons. According to the Ellinger-Castle classification we have studied in nerve muscle physiology. And what are they going to release? They're going to release acetylcholine at a effector organ, that is a skeletal muscle. And we have this receptor over here, that is the N1 receptor, or I can call it the nicotinic muscle end plate wala receptor. Okay, so the somatic nervous system is one branch of the central nervous system. Okay, that is under our voluntary control. The next one that we actually have is your autonomic nervous system, that is the ANS. And ANS की ही दो divisions हैं. We have the sympathetic nervous system and we have the parasympathetic nervous system. So let's just see what are the some of the differences between your sympathetic and your parasympathetic nervous system. Okay, just at the onset, I want to show you this diagram. Just remember, this is a very super duper important thing. Can you see the ganglia? Okay, so we have a preganglionic neuron. It's going to make a synapse onto a ganglia, and then from that ganglia, we're going to have a postganglionic neuron. I think that makes sense. In case of your sympathetic neurons, the preganglionic neurons, they're going to release acetylcholine. Okay, this is very important. They're going to release acetylcholine, and these preganglionic neurons are type B fibers according to the Ellinger-Castle classification. So type B, they're also again myelinated neurons. All right. So this is acetylcholine. This is going to work on the ganglia. यहाँ पे जो हमारे ganglionic neurons हैं, at which receptor? Not the N1 now, it's N2. That is nicotinic nerve वाला. ठीक है, that's mainly your जो ganglia पे receptors है nicotinic वाले. N2 कह सकते हैं या N type of receptors कह सकते हैं. And whatever neurons are going from there, that's the postganglionic neurons. Just remember they're type C fibers, मतलब they're unmyelinated. ठीक है? And what do they release? Predominantly, they're going to release norepinephrine. There's an exception over here. That is postganglionic sympathetic neurons. They release acetylcholine only at one place. That's your sweat glands. All right. So sympathetic preganglionic neurons are myelinated. They're type B fibers. They release acetylcholine onto the ganglia. Okay. And from the ganglionic neurons, जो भी हमारे post ganglionic neurons they're going to release either noradrenaline most of the cases, most of the times, and in some cases, that is in your sweat glands, we're going to have acetylcholine. So can I say any neuron when it releases acetylcholine, I'm going to call it as a cholinergic neurons. Okay, cholinergic. So what are cholinergic neurons? Ones are preganglionic, सारे के सारे preganglionic fibers, whether it be the sympathetic neuron, sympathetic nerve system के fibers or your parasympathetic nerve system के fibers, they're going to release acetylcholine as we have just seen. And the second one are your mainly sweat glands. Sweat glands, when they're supplied by the sympathetic nervous system, again, postganglionic neurons, which are supplying the sweat glands, they're also releasing acetylcholine. And what about the third portion? Let's see. So this was about that. If you see the sympathetic chain, this is the ganglia here, they're arranged in a sympathetic chain, as we have seen. Okay? Paravertebral, we have these chains known as sympathetic chain. Can you see if this is the effector organ, where is the ganglia? It is located away from the effector organ. ठीक है? So as you can very well see, जो हमारे pre-ganglionic neuron का जो length है, that's very short, right? As compared to the post-ganglionic. That's one thing. And the second thing of all, that is your ganglia located away from your effector organs. Okay? I'm telling you the salient features of the sympathetic nervous system. What about the parasympathetic nervous system? If you see the parasympathetic nervous system, the first thing that I can see is the preganglionic neuron, they're going to release acetylcholine, just as we have discussed. Every preganglionic neuron, whether it's from the sympathetic nervous system or from the parasympathetic nervous system, is going to release acetylcholine, which is going to work on the N2 receptor, that is NN type of receptor. And now, जो भी हमारे post-ganglionic neurons हैं, what are they going to release in case of parasympathetic? They're going to release acetylcholine now. ठीक है? So what are the things which release acetylcholine? Every preganglionic neuron, whether it be belonging to the sympathetic nervous system or from the parasympathetic nervous system, is going to release acetylcholine. One. The second one was the exception. कि post-ganglionic sympathetic fibers, they release acetylcholine only at one side, that's the sweat glands. One they release norepinephrine. And the third thing that we see is every post-ganglionic parasympathetic neuron is also going to release acetylcholine. So these are all our cholinergic fibers. Okay? As in case of somatic nervous system, it was the myelinated A alpha fibers. In case of sympathetic and parasympathetic, the preganglionic fibers are type B fibers. Okay? They're myelinated according to Langer-Gasser. And जो भी हमारे post-ganglionic है, they're type C fibers which are unmyelinated. Okay? And the last thing, parasympathetic neurons का ganglia देखो, they're close to the effector organ. So that means जो preganglionic neuron की जो length है, that is considerably longer as compared to your sympathetic. Sympathetic की because the ganglia were located away from the sweat glands and the sympathetic have to originate from your thoracolumbar spine. इस केस में जो preganglionic neurons है, उनकी जो length है, that's going to be shorter in case of your sympathetic nervous system. And what about the adrenal medulla? We know adrenal medulla is also going to release acetylcholine from the preganglionic neurons into the adrenal medulla. Okay? And from there, we're going to either have release of your epinephrine. 90% it's epinephrine, followed by norepinephrine that makes for 10%. And last, we have some other hormones like your dopamine. Okay? All right. So we have seen. All right. Somatic nervous system was controlled mainly by your cerebral cortex. What about the autonomic nervous system? So the autonomic nervous system is mainly controlled by your hypothalamus. And what do I mean by that? जो हमारा anterior hypothalamus है, guys, that's going to mainly have an excitatory effect on the parasympathetic nervous system. And your posterior and lateral hypothalamus is going to control mainly your sympathetic nervous system. Okay? All right. So let's move forward. So this is what I was talking about. The posterior area of the hypothalamus is going to activate the sympathetic nervous system, and your anterior areas of the hypothalamus is going to activate your parasympathetic nervous system. Okay? All right. So this is the table that I'm going to talk to you about. The sympathetic nervous system, if you see, कहाँ पे उनका origin है, that's mainly thoracolumbar. ठीक है? That is T1 से लेके T12 and L1 से लेके L3. So this is thoracolumbar. What about the parasympathetic? It's mainly craniosacral. Along with that, we have some cranial nerves which are associated with the parasympathetic nervous system. What are they? We have 3, 7, 9, and 10. That makes sense. What about the ganglia? Ganglia is away from the organ supply, as we saw, but ganglia is on or close to the organ supply. Okay? What about the length of the preganglionic nerve axon? This was shorter, right? And you can wonder why. Whereas in case of parasympathetic, it's mainly longer. What was the neurotransmitter in the ganglion? Both cases made acetylcholine. Okay? What is the receptor type in the ganglion? It is again nicotinic type. That is NN type of receptor. That is N2. Okay? What about the length of the post-ganglionic nerve axon? किस case में longer होगा? In case of sympathetic nervous system, it's going to be longer because the ganglia is away from the effector organ. इस करके post-ganglionic nerve axon is going to be longer in case of the sympathetic nervous system. Right? We know they have some effector organs. बहुत सारे हैं. We know that. What about the neurotransmitter? इस case में it's mainly norepinephrine. And in case of parasympathetic, it's mainly acetylcholine. If I have to say minor neurotransmitters, sympathetic nervous system में, they mainly could be ATP and dopamine as well. And in case of parasympathetic nervous system, as you study the enteric nervous system in your GIT physiology, we know there are mainly the VIP, that is vasoactive intestinal peptide, and nitric oxide was also playing a very important role in your mainly your mind reflexes. Okay? So this is the thing. And what about the somatic ones? They're mainly supplying the skeletal muscles. And what is the neurotransmitter being released? That's acetylcholine. And what is the receptor? That the receptor mainly will be N1. That is NM type of nicotinic type of receptor. Okay. All right. Just remember, there are some organs which only have a sympathetic supply. What are they? Blood vessels predominantly, they're only going to have a sympathetic supply. Okay? Sweat glands are going to have only a sympathetic supply, and your hair follicles are going only to have a sympathetic supply. What about the parasympathetic supply? And I can add one more, that only sympathetic supply, the ventricles. Okay? The ventricles are only supplied by the sympathetics, and they don't have any influence of the parasympathetic over the ventricles. Okay? What about the parasympathetic? What are those organs which only have a parasympathetic supply? One would be your ciliary muscle. Okay, ciliary muscle has only a parasympathetic supply. All right. Then you have the gastric glands and your pancreatic glands. Okay. And we know that there is one more nervous system that we have over here, guys. That is your enteric nervous system. And we have already discussed about the myenteric and your submucosal mucinous plexus as well. So the myenteric plexus that was lying between the two layers, that is outer longitudinal and your circular muscle layer, and your submucosal that was lying in the submucosa, also known as the mucinous plexus. The myenteric plexus was the one which was mediating your peristalsis and other type of GI motility, whereas submucosal was mainly concerned about your secretions and your blood flow. Okay, all right. So let's move forward. Right. So these are the different actions that we're going to discuss. कि sympathetic action क्या है हमारा and parasympathetic action क्या है. So let me just give you a brief overview. When we talk about the heart, in case of the sympathetic action, mainly it's going to increase the heart rate, it's going to increase the contractility, as well as it's going to increase your AV nodal conduction. Okay. And what is the receptor that we have in the heart? It's mainly beta 1 type of receptor. Okay. What about the parasympathetic? Parasympathetic is going to decrease the heart rate, it's going to decrease the contractility of the atria, and it's going to decrease the AV nodal conduction. Did I say, guys, did I mention atria? Why am I saying atria specifically? Because the parasympathetic nervous system does not supply the ventricles. Okay. And which type of receptor will mediate all of this? Mainly हमारा M2 type of receptor will mediate all of this. So beta 1 in case of your heart for sympathetic nervous system, and M2 in case of parasympathetic nervous system. Okay. What about the vascular smooth muscles? All right. So vascular smooth muscles, sympathetic action भी हो सकती, अगर alpha 1 type of fibers है, they're going to serve as vasoconstriction, whereas beta 2 अगर हमारे receptors हैं, they're going to mediate vasodilation. What about the parasympathetic? We're going to see about the parasympathetic because that will be a slightly bit complicated. So let me just tell you अभी थोड़ा सा, अगर parasympathetic nervous system हमारे endothelium पे act करता है, it's going to function as a vasodilation. Okay, so the main effect that we'll get is vasodilation, and we might get a fall in BP. But if it directly acts on your smooth muscle cells, that is कि मान लो endothelium injured है, then we're going to have vasoconstriction. And why does that happen? We're going to see shortly. Okay. What about the GI tract? Sympathetic action is mainly your fight and flight. Those time you don't want your GIT to function. Okay. You need to shunt all of that blood away from your other vital structures. Okay. Not your GIT takes the least importance. So you would want to decrease your motility and you want to constrict the sphincters. Whereas in case of your parasympathetic nervous system, it's mainly the rest and digest system. So it's going to increase the motility and relax the sphincters. Okay. What about the bronchioles? Because of beta 2 receptors, we're going to see bronchodilation in case of your sympathetic action, whereas in parasympathetic action we're going to see is going to constrict the bronchial smooth muscles mainly as a result of M3 action. Okay. What about, this is important again, male sex organs में ejaculation is mainly mediated by a sympathetic action, whereas erection is mainly mediated by a parasympathetic action. Okay. Erection in this case is mainly via the S2 से लेके S4 splanchnic nervi adgentis, I would say. And these fibers actually, they may release acetylcholine and that can lead to vasodilation. But one more thing we have seen there are some NANC fibers as well. What are they? Non-adrenergic, non-cholinergic fibers. They mainly release nitric oxide. Okay. So nitric oxide is also one which plays a very important role in case of your erection. And that is the reason why that cyclic GMP, जो nitric oxide stimulate करेगा production, cyclic GMP is broken down by phosphodiesterase. Okay. And this is the portion where your drugs that we use for erectile dysfunction like your sildenafil will work because they inhibit the phosphodiesterase. Okay. What about the bladder now? If you see the sweat glands, mainly I told you sweat glands is one of those portions जहाँ पे sympathetic supply है, and you know very well guys कि cholinergic fibers. Okay. So they are postganglionic cholinergic sympathetic nerve fibers that we're talking about in case of your sweat glands. What about the kidney? In case of sympathetic action, it's mainly going to increase your renin secretion via the beta 1 receptors. And what about the fat? Fat के case में it's going to increase your lipolysis. They mainly mention beta 1. I would say beta 3 also has a very important role in case of your fat. Because we are developing some beta 3 agonists which might function as anti-obesity drugs in case of the future. Okay. All right. So this is the structure of an NM type of receptor. Okay. What is this NM type? We've already discussed in nerve muscle physiology that we have two alpha 1 receptors, alpha 1 subunits of this NM type of receptor. We have a gamma subunit, we have a beta subunit, and we have a delta subunit. Okay. Acetylcholine is going to bind to this receptor. And what is this kind of a receptor? This is what I call as an inotropic receptor. What do I mean by that? Okay, whenever a ligand is going to bind to it, it's going to function as a channel and it's going to allow your sodium coming inside. Okay, that is what I mean by an inotropic receptor. So where are the acetylcholine binding sites? It's mainly between alpha and delta, and it's between alpha and gamma. So these are the two acetylcholine binding sites. Okay. All right. And we've already discussed about something about the action potential. So I would like you to uh, go previously, पिछली videos में we have already discussed nerve muscle physiology. So आज we won't be discussing them, but I've included in the note because we get a sense of your integration, right? So we have already talked about your action potential. All right. All right, one more, guys. Though MCQs in case of pharmacology, I've already told you in nerve muscle physiology that we have two toxins. All right. So sodium channels को block करने के लिए we develop a toxin. We develop a toxin that's known as a tetrodotoxin. And in case of to block the potassium channels, we have some compound that is known as triethyl ammonium ion. Okay, that's going to function as a potassium ion and not going to allow your potassium to go inside the potassium channels. So we have sodium channels को block करने के लिए tetrodotoxin and tetraethyl ammonium to block your potassium channels. Okay. All right. And we seen कि जो भी हमारे यहाँ पे synaptic boton है and that's whatever the neurotransmitter is going to release, we have already talked कि we have some major neurotransmitter that is sympathetic nervous system में हमारा norepinephrine and parasympathetic nervous system में हमारा your acetylcholine. But we also have some co-transmitters. What do I mean by co-transmitters is once acetylcholine is released or once noradrenaline is released, we're going to have some substances which are going to be released along with that cycle. Okay, what are those substances? For example, sympathetic nervous system में we have ATP as a co-transmitter. Okay, we're going to and mainly if you talk about the co-transmitters, we have talked about ATP and your neuropeptide Y in case of your sympathetic nervous system. And parasympathetic nervous system में we have some co-transmitters that's mainly your nitric oxide and your VIP. Okay, and if we talk about your fastest to slowest action of these neurotransmitters, I would say ATP is the fastest in case of sympathetic nervous system, and parasympathetic nervous system में again it's acetylcholine which is the fastest. All right, as in case of your transduction, I would say. Okay, and we've already talked ki how are these vesicles जो हैं, basically they get docked via these proteins known as the snare proteins. I would like you to refer you back to your nerve muscle physiology that we have some proteins known as snare proteins, and we'll be discussing a toxin known as a botulinum toxin in great detail abhi, that's going to target these snare proteins. Okay, so just remember vesicles are docked onto the postsynaptic membrane because we have some proteins known as your snare proteins or your snare receptors. Okay, all right. We're going to talk about two of these clinical syndromes as well. That is your myasthenia gravis and your Lambert-Eaton myasthenic syndrome, LEMS and your myasthenia gravis. We're going to talk about that shortly, and we're going to discuss the various drugs that we use in the case of myasthenia gravis and your LEMS. All right. About the vesicles, again as a MCQ, I would say small clear vesicles जो है हमारे, they mainly are containing acetylcholine, glycine, GABA, and glutamine. When I talk about the small dense core vesicles, they're small but they're dense. That is mainly your catecholamines because that is what we are studying right here. So noradrenaline, adrenaline, dopamine, all of these are stored inside these small dense core vesicles, whereas your acetylcholine is stored inside these small clear vesicles. Okay, and we've already discussed about something known as the active zone, जहाँ पे हमारे maximum concentration of calcium होता है, and that we know because calcium is the one that's going to do two things in our body: exocytosis, and the second one is your contraction. So this case it's sort of like an exocytosis mediated by the snare proteins. Okay, because the snare, the calcium is going to bind with synaptotagmin, that's a snare protein, and that's going to mediate your fusion of the fusion of the vesicle with your prejunctional membrane. Okay. All right. So now we're going to talk about the cholinergic system. So let's just see the synthesis of your acetylcholine, and then we're going to see some of the drugs which act here. All right. Okay. So we're going to have a structure, we are going to have a compound that's choline, and we have acetyl-CoA, which we have derived from the TCA cycle. Okay? So we have choline and we have acetyl-CoA. We're going to combine via this enzyme known as CAT, that is choline acetyl transferase. Okay? So acetyl-CoA will transferase kar dega to the choline molecule, and now we're going to have formation of acetylcholine. Okay? That makes sense. This is the vesicle just telling you about. It's a small clear vesicle. Acetylcholine is taken inside that vesicle via a transporter which is known as your VAT. That is all right. So this is the transporter that we have. That is your VAT. It's an acetylcholine H positive exchanger. Acetylcholine H positive exchanger. Okay. So this acetylcholine gets inside this vesicle. All right. And now it's going to get released. Once it gets released, it's going to act on two types of receptor that we have for the parasympathetic nervous system. We either have the nicotinic receptors and we have the muscarinic receptors. Okay, and we talked about if we have some snare proteins which are going to be inhibited by something known as a botulinum toxin. Okay, we're going to talk about that. Once this acetylcholine is released over here, we have an enzyme here at the post-junctional membrane that's known as acetylcholine esterase, which is going to break down the acetylcholine again into your acetyl CoA and your choline. And this choline that is in the extrajunctional space is going to be again taken up by the जो हमारा synaptic terminal है वो उसे वापस ले लेगा by this choline uptake, ठीक है, which is mediated by a sodium choline transporter, ठीक है, sodium choline transporter. What are the drugs that we have actually here? So this transporter, that is VAT, is inhibited by something known as visamicol. Okay? Visamicol. So these are all of these drugs which I'm discussing right here. They are not of any clinical significance. They're just of scientific significance. So you have visamicol functioning as a VAT inhibitor that's going to transport your acetylcholine into the vesicle. And the second drug that I'm going to tell you about is hemicolinium, which is going to inhibit your sodium choline co-transporter. Okay? So hemicolinium and we have visamicol, and we've already talked about the botulinum toxin as well. So this is the receptor that is an NM type of receptor. When I want to discuss about the NN type of receptor, that is mainly your ganglia may present, we're not going to discuss its structure in great detail, but we've already talked about the NM type of receptors and how does it have the different subunits, that is the alpha, gamma, delta, and your beta subunits. And don't forget the acetylcholine binding site between the alpha, delta, and your alpha, gamma sites. Now, we're going to talk about the botulinum toxin now. As we saw, we have some snare proteins. Okay? So just remember, the toxin, that botulinum toxin, is a toxin that we have derived from your Clostridium botulinum. ठीक है, it's an anaerobe Clostridium botulinum. उससे हमने toxin derive किया है, and the toxin that we use in clinical practice is your toxin A. ठीक है, so this toxin A, if you look at this table, this toxin A is going to inhibit your SNAP25. ठीक है, so this SNAP25 is a terminal snare present on the prejunctional membrane. ठीक है, and ये जो हमारा botulinum toxin is going to inhibit it. So what's going to happen is, जो हमारे यहाँ पे acetylcholine है, right? So this is the thing, and I'm saying यहाँ पे हमारा cycle है, this is going to contain acetylcholine, and I'm saying यहाँ पे कई सारे proteins हैं, they are known as your snare proteins, alright? And उन snare proteins में से I have this SNAP25. Once this is inhibited by the botulinum toxin, I'm not going to have acetylcholine का release. That is the thing that it's doing. Acetylcholine का release is prevented by these inhibition of these SNAP proteins, which are functioning कैसे, वो vesicle को pre-junctional membrane से फ्यूज करवा रहे थे, सो दैट एसिटाइलकोलिन जो कि वेसिकल में है दैट गेट्स रिलीज्ड, ठीक है, इनटू द सिनैप्टिक क्लेफ्ट, एंड देन वी हैव द फर्दर मेनली योर प्रोपगेशन ऑफ दैट सिग्नल, ठीक है, जो भी हमारा केमिकल साइनैप्स के थ्रू है. बट यहाँ पे SNAP25 को इनहिबिट करके एसिटाइलकोलिन का सिंथेसिस इज प्रिवेंटेड. एंड व्हाट इज दिस काइंड ऑफ अ ब्लॉकर? इट्स अ इरिवर्सिबल ब्लॉकर. इसका मतलब ये है that until or unless the new nerve terminals are not formed, which is going to take roughly about 3 months, okay? So nerve generation, as we know, a nerve is going to get formed at about 3 months. So tab tak irreversible block rahega, and until and unless we don't have new protein synthesis, new nerve synthesis, the block is going to stay. So matlab botulinum toxin has a long duration of action. And what are the things that we use for? It's mainly given as a local injection. Local route se hum dete hain ise intramuscularly. And what is the dose that we give actually? Dose, it's mainly 50 से लेके 300 units तक जा सकता है. And what are the indications? We can use it for wrinkles, for cosmetic purposes. We can have blepharospasm, cerebral spasticity. It has also been approved for your migraine prophylaxis as well. Torticollis के लिए दे सकते हैं, especially spasmodic torticollis, spasmodic dystonia. We can give it for your strabismus or nystagmus के prevention, nystagmus के treatment के लिए, and even for your spasmodic dysphonia. ठीक है, so all of these are the indications, mainly spastic conditions, जहाँ पे हमें acetylcholine नहीं चाहिए. क्यों? Because this acetylcholine was working on the muscle via the NM receptor, and वो muscle का contraction हो रहा था. इसमें we have already decreased the muscle contraction. In case of wrinkles, wrinkles के case में it's mainly the facial muscles का contraction which is generating these wrinkles present on our skin. So by relaxing those muscles, हमने wrinkles को भी ठीक कर दिया. So all of these conditions are mainly spastic conditions that we want to prevent by using this botulinum toxin. Long duration of action, 3 months के लिए. ठीक है? Alright. As we saw abhi recently, we've discussed about the synthesis, and we discussed mainly यहाँ पे हमारा acetylcholine is getting released over here. Taken. What about next? At the post-junctional membrane, we're going to have something known as the acetylcholine esterase. So this is an enzyme which is going to cleave your acetylcholine back into choline and acetate. Okay? And this choline gets reuptaken by the sodium choline transporter. Okay? Alright. So this is the structure of this acetylcholine esterase. So let's just see what happens actually. So if you look at the choline structure mainly, so this is the choline bit. You can see choline has a quaternary ammonium that is positively charged, okay? And it's going to have this acetate portion as well. Now this enzyme, जो acetylcholine esterase, it has 2 binding sites, okay? It has an anionic site, मतलब negatively charged, and it has an esteric site, okay? An ionic site and an esteric site. Anionic site पे mainly glutamate है, एस्टरिक साइड पे मेनली इट इज सेरीन. सो व्हाट हैपेंस हियर गाइस इज कि यहाँ पे दिस कोलिन का जो नाइट्रोजन है, क्वाटरनरी नाइट्रोजन है, दैट्स गोइंग टू गेट अट्रैक्टेड बाय दिस एनायनिक साइड. सो यहाँ पे वो बाइंड कर गया. ठीक है. व्हाट अबाउट हियर, यहाँ पे भी जो हमारा एसिटाइल कोलिन वाला जो कार्बोनिल ग्रुप है, COO वाला जो ग्रुप है, दैट्स गोइंग टू इंटरैक्ट विद योर हाइड्रोक्सिल ग्रुप ऑफ सीरीन. एंड व्हाट एग्जैक्टली हैपेंस इज नाउ वी आर गोइंग टू सी हाइड्रोलिसिस. और यहाँ पे हाइड्रोलिसिस अगर होगा, वी आर गोइंग टू जनरेट योर एसिटिक एसिड and your choline again. So this is what is happening. We have the anionic side, we have the astatic side or the estric side. ठीक है. Anionic side पे glutamate present है, estric side पे हमारा serine present है. Anionic side पे electrostatic attraction के कारण choline gets attracted and mainly we cleave the bond which are present over here. So this is an ester bond, right guys? So this is a ester bond that I am talking about. So कोई भी ester bonds in the body, so this enzyme can work over there. ठीक है. So let's just see. Actually there are two kinds of your choline esterases. We have acetylcholine esterase, that is ACHE, जो हमारा proper है, and we have something known as the pseudocholine esterase, that's also known as butyrylcholine esterase. ठीक है. So what are the locations, guys? Acetylcholine esterase के case में the location is on the synaptic cleft 1. ठीक है. जो हमारा mainly जो हमारा क्या है, जो भी हमारा nerve terminals है, when they release acetylcholine on the post synaptic membrane, तो यहाँ पे post synaptic membrane पे यहाँ पे हमारा acetylcholine esterase है, which is going to cleave your acetylcholine. And जो choline है, we have talked about how is it reuptaken by the nerve terminal. ठीक है. So in synaptic cleft में हमारा acetylcholine esterase present है. The second location for your acetylcholine esterase is on your RBC. ठीक है. So RBC में there is a special type of acetylcholine esterase known as an RBC esterase. Why this is important? Because we have a drug known as esmolol. It's a beta blocker. So this esmolol is very short acting. ठीक है. And why is this so much short acting is whenever we administer it, जो हमारा RBC esterase है, that's going to cleave this ester bonds which are present on your esmolol, and that's going to metabolize your esmolol. ठीक है. And the third region that with this acetylcholine esterase is present is the gray matter of the brain. As we know, brain में हमारा mainly acetylcholine is one of the excitatory neurotransmitters. I would say the predominant excitatory neurotransmitters along with glutamate is your acetylcholine. तो वहाँ पे भी we need something to cleave your acetylcholine back into your acetate and choline. ठीक है. What about the pseudocholine esterase? This pseudocholine esterase की जो main primary location है, that's in the plasma, and it goes by the name of plasma esterase. The second region that there is present is in the tissues, and mainly in the liver cells, and that's known as tissue choline esterase. So we have plasma esterase and then the tissue choline esterase. Okay. Now the pseudocholine esterase is the one which is going to serve as your main thing that's going to metabolize your other drugs that you're administering. For example, succinylcholine. Succinylcholine is it's a skeletal muscle relaxant that we use. Okay. So this succinylcholine क्या है? It's basically like दो acetylcholine को आपने इकट्ठे जोड़ दिया. Okay, so that is a succinylcholine. The second thing that the pseudocholine esterase can hydrolyze is mainly your mevacurium. That's again a drug that we use. It's again a skeletal muscle relaxant, and your procaine. So these are all cleaved by your pseudocholine esterase. Where is it present? It's present again second side जो हमारी liver cells में present है, मतलब tissue choline esterase के नाम से, is present in the white matter as well. Okay, so these are the first differences that's between acetylcholine esterase and your pseudocholine esterase. What about the second one? जो हमारा acetylcholine esterase है, that does not have any genetic variation. मतलब everyone is going to have the same amount of your acetylcholine esterase. But in case of your your pseudocholine esterase, that's also known as your butyrylcholine esterase, we're going to see that it's going to have some genetic variation. ठीक है. मतलब we call something known as the atypical choline esterase. ठीक है. That's your defective enzyme. और how do we calculate it? You will study it in anesthesia. That's known as a Deboucaine number. ठीक है. So that's known as your Deboucaine number. So what is this Deboucaine? Deboucaine is a compound which is going to attenuate your normal enzyme action. पर atypical वाले को वो छोड़ देगा. ठीक है. That is the main thing. तो normal जो Deboucaine number है should be 80. मतलब 80% attenuation of your butyrylcholine esterase. ठीक है. And जैसे जैसे जो हमारा atypical enzymes के levels पढ़ेंगे, we're going to see that the amount of attenuation is going to fall now. Why? Because we have more amount of atypical choline esterase as compared to your acetylcholine esterase. ठीक है. So heterozygous people में the Deboucaine number might be 40 to 60, and homozygous people में it may be even 20 or less. मतलब there is only slight attenuation noted. Why? Because the Deboucaine is only going to attenuate your normal enzymes and not your butyrylcholine esterase. So that is something known as the Deboucaine number, which we use because that is in case of your succinylcholine, whether we have the enzyme present or not. Okay, so normal, heterozygous and homozygous के case में what are the Deboucaine number we have seen. What about next thing? Acetylcholine esterase के there is no variation in the concentration, whereas butyrylcholine esterase will depend upon your plasma volume because it's present in the plasma. In case of hypervolemia, we're going to see a fall in the plasma concentration of your butyrylcholinesterase or your pseudocholinesterase. In case of dehydration, because the plasma volume हमारी कम हो जाएगी, we're going to see an increase in concentration. Whereas in pregnancy, which is a state of your hemodilution, we're going to see a fall in your pseudocholinesterase as well. In case of liver failure, because हमारा tissue cholinesterase is not there, that's a type of your butyrylcholinesterase, again we're going to see a decrease. Okay. Acetylcholinesterase का main जो action है on our body, that's the termination of your acetylcholine action, which is the normal thing. Whereas pseudocholinesterase is going to cleave any amount of ester bond which is present. Okay, whether it is your procaine, whether it is your different succinylcholine, whatever, जो भी हमारे other ingested esters, whatever drugs that you're consuming from outside, उन सबको संभालना is mainly your job of pseudocholinesterase. One exception I would say is your RBC esterase, that's a type of acetylcholinesterase which was metabolizing your esmolol. Okay, all right. ठीक. So now we're going to talk about the different receptors. We've already talked कि हमारा N1 receptor क्या है. We've already talked about N2 receptor क्या है. ठीक है. Now we're moving on to your muscarinic receptors in case of your parasympathetic nervous system. ठीक है. Muscarinic. As you've seen in endocrinology, we have something known as G protein coupled receptors and how do they work. So let me just tell you. We have we have 5 types of muscarinic receptors, but we only have drugs for 3. So M4 and M5, I would say, they mainly are present in the CNS, and we actually don't know what do they do. Okay, so we'll not be studying your M4 and M5, and neither we have any drugs which are available for M4 and M5 type of receptors. Okay, so let's talk about the M1 receptor. Where is the M1 receptor present? So mainly it's present at the ganglia. One thing. So it's going to be present at the ganglia. It's going to be present at the gastric glands. And gastric glands may be kahan pe actually? Not on the parietal cells, mind you. It's going to be present on the ECL cells. Guys, you must be remembering enterochromaffin-like cells, which are releasing what? They were releasing histamine. Okay? They were releasing histamine. And we already talked about the cooperative synergism जो कि होता है in case of your gastric acid secretion, जहाँ पे हमारा histamine is going to work on the H2 receptor present on the parietal cells. ठीक है? All of them were mediated by vagus, and we talked about all of that as well. ठीक है? So just remember M1. The M2 type of receptors are mainly present in your heart, and the M3 type of receptors are going to be present elsewhere. Okay? So let me just, if they're G protein coupled receptors, it won't hurt if we remember how do they work. So M1 and M3 type of receptors, M1, M3 and M5, they're of one category because they're linked via GQ. And we know GQ is mainly linked via phospholipase 3, IP3 DAG pathway. Jisme we're going to see an increase in calcium as a messenger system. Whereas your M2 and M4 type of receptors, they're mainly linked by your GI type of receptors, that is inhibitory. So how do they work? They're going to inhibit your adenyl cyclase, decrease the amount of cyclic AMP. Okay? So when we are talking about your M1 receptors, don't forget the GQ protein link, and increase in calcium is going to be the second messenger over here. Okay? Right. What about the M2 receptors? M2 receptors are, as I told you, they're present on the heart. Beta 1 for your heart in case of sympathetic nervous system, and M2 in case of your parasympathetic nervous system. तो अगर वो ऐसे नोड पे वर्क करेंगे तो मेनली they're going to decrease what? They're going to decrease your heart rate. ठीक है? If they're going to work on the AV node, क्या होगा? AV node we know वहाँ पे हमारे slowest conduction होती है. They're going to even by hyperpolarizing the AV node, they're going to even function as negative bromotropic action. मतलब वहाँ पे velocity को भी वो कम कर देगा. So you're going to decrease the velocity of your conduction. So it is negative inotropic. Oh, sorry, negative chronotropic, negative dromotropic. If I talk about the atrium, they might be negative inotropic as well. But just remember, guys, ventricle may contractility is slight, I would say, or maybe it is not even affected at all. Okay? Because parasympathetic supply to the ventricle is not there. Okay? Right. What about the M3? M3 हमारे कहाँ present है? They present elsewhere. But हमारे सारे bronchial smooth muscles, सारे visceral smooth muscles, they're going to suffer. They're going to have contraction via the M3 receptors. Whatever secretion that we are accomplishing, जो भी हमने parasympathetic supply में पढ़ा था, whether it be your gastric secretions via the parietal cells, M3 type of receptors हैं वहाँ पे, whether it be your pancreatic secretion by the acini, whether it be your mainly your salivary glands, whatever जो भी हमारी secretion are present in the GIT, they're mainly going to be mediated by M3 type of receptors. So हमारी exocrine glands का secretion is by M3 type of receptors. Okay. What about the ciliary muscle? As I told you, contraction again by the M3 type of receptors. Why? All of this contraction is happening by what? Via calcium. And this makes sense because IP जो हमारे M3 type receptor है, it's mainly a GQ link type of receptor. And what about next one? I told you guys, vascular endothelium, okay, it's going to mediate vasodilation. Okay. Whereas if you work on the smooth muscle, is going to mediate vasoconstriction. So how is this happening? Okay, vascular endothelium में it's going to mediate this vasodilation by nitric oxide. So nitric oxide, as we've discussed in CVS, is also known as the endothelial derived relaxing factor, that is EDRF. This is the nitric oxide that we talked about. So these are the different receptors that we have. M1 present in the ganglia, present in the CNS, present at the mainly your enterochromaffin-like cells. M2 type present at the heart predominantly. And what about M3? Present in the smooth muscles, present in the exocrine gland, they're going to mediate increase in secretion, present at the vascular endothelium, that's going to mediate vasodilation. And we have discussed all of this. Okay. You might remember, it won't hurt you to remember, there are some agonists and some antagonists of these receptors. So these are all just for MCQ, you can just see. So M1 ke liye, we have the typical agonist that is there, that's oxotremurine. In case of M2, it is methacholine, and in case of M3, it is bethanechol. Okay, we'll be using bethanechol very shortly when we're discussing the choline esters. Okay, cholinergic drugs. What about the M1 blockers now? Very important is pyrenzepine. Before we had your H2 blockers or your proton pump inhibitors, pyrenzepine was a very popular drug that we used to give for a peptic ulcer disease. But since we have better drugs at abolishing your acid secretion, pyrenzepine has gone out of fashion. Okay, all right. M2 के blockers we have methotrexate and tryptamine, and last में M3 के blockers very important are solifenacin and dorifenacin. We'll be studying about the vasicoselective your anticholinergics as well. ठीक है, तो वहाँ पे we're going to study about solifenacin and darifenacin. ठीक है, all right. So discuss, we have the NN type of receptor, NN type of receptors. We discussed about the different muscarinic type of receptors as well. We discussed M1, M3, M5 are linked by GQ, and M2, M4 are linked by GI type of receptors. Okay, all right. Here's a very important, interesting thing for you guys. Whenever we talk about addiction, okay, so this might be seeming as thoda sa complicated, but just when we talk about addiction, mainly we talk about two centers present in our brain. We have the ventral tegmental area, okay, and we have something known as the nucleus accumbens. Okay, so we have nucleus accumbens and ventral tegmental area. Okay, and all of these drugs, whether it be your cocaine, whether it be your any addicting drug, whether it be your alcohol, nicotine, all of them are going to work at your ventral tegmental area, and that's going to mediate you. Hello guys, so sorry for the interruption guys. But यहाँ पे I just wanted to tell you about this drugs known as varenicline. So this varenicline will block this alpha 4 beta 2 type of nicotinic receptor. Okay, that is nicotinic receptor, and it's going to function as what? It's going to mediate your all right. I think I'm audible. Okay, so this varenicline, just remember, it can be used to mainly your as a de-addiction. We have this drug, okay, varenicline, which is going to work on an alpha 4 beta 2 type of nicotinic acetylcholine receptors present in the brain. Okay, not the NM type of receptors, but we are talking about the NN type of receptors, and one of them are your alpha 4 beta 2 receptors. Okay, all right. All right, as we talked about the heart as well, we know the M2 type of receptor is going to mediate a couple of things as we studied in CVS physiology, that we know whenever we are going to have a decrease in cyclic AMP, that's going to have decreased activation of these special channels which we were talking about that were known as the funny channels, HCN channels, hyperpolarization cyclic nucleotide gated channels. And whenever we saw कि वो channels अगर close होंगे, जो हमारा pre-potential का slope है, that's going to decrease. तो उसके कारण क्या होएगा? We're going to see a decrease in the heart rate as a negative chronotropic action. What about negative chronotropic action? It's going to decrease the contraction of the atrial muscles. So atrial muscles के case में it might be negative inotropic, and it is definitely negatively dromotropic. No parasympathetic supply of the ventricles, as I've already told you. Okay. So now we're going to talk about the different actions of your acetylcholine per se. Okay. So let's see. On the bronchial smooth muscles via M3 type of receptors, it's going to mediate bronchoconstriction. One, it's going to increase every secretion present in the body. What are they? They're going to increase lacrimation, they might increase salivation, sweating, exocrine actions. We're talking about acetylcholine, guys. Acetylcholine's actions on the body. Okay? All of these actions are mainly mediated by M3 action, except your M2, which was mainly your heart. Okay? The bronchoconstriction, increase in secretions. When we're going to have ciliary muscles ka contraction, we're going to have accommodation, as we know. So you might study about this von Helmholtz capsular theory in case of ophthalmology. So वहाँ पे guys, just remember, whenever we're going to have contraction of the ciliary muscles, जो हमारे जो zonules है, they're going to basically relax. ठीक है? And whenever the zonules are basically going to relax, so जो lens is going to become more conoidal. ठीक है? It's going to become more spherical, less flat. जिसके कारण accommodation for nearer objects we can accomplish. So ciliary muscle की contraction से हमारे acetylcholine, why the third nerve is going to mediate accommodation. Okay? And we know iris में we have two types of we basically have two muscles. We have the sphincter pupillae and with the dilator pupillae. Dilator pupillae is mainly under the sympathetic control. Okay, sympathetic nervous system, whereas we have the sphincter pupillae that's under your parasympathetic nervous system. So whenever this parasympathetic nervous system के through sphincter pupilla will contract, we're going to see meiosis. Okay, and I think that makes sense. All right, so this is what I was talking about, van capsular theory, right? Von Helmholtz theory of your capsule, and how does it control your accommodation. Okay, what about the heart? We've already talked about the things which happen at the heart, and this is what I was telling you guys कि blood vessels पे क्या होएगा. ठीक है, so whenever it's मतलब हमारा acetylcholine अगर आएगा, it's going to function mainly on the endothelium. And what is it going to do to the endothelium? वहाँ पे endothelium में we know there's an enzyme known as ENOS, that is endothelial nitric oxide synthase. So this acetylcholine, if you see, it's going to stimulate your NOS, and that's going to convert your arginine into citrulline, and we're going to have nitric oxide as a byproduct. And this nitric oxide being a gas, it's going to diffuse into the smooth muscle cell, going to stimulate your guanyl cyclase, that's going to generate your cyclic GMP, and that cyclic GMP is going to activate this protein kinase G, protein kinase A for cyclic AMP, protein kinase G for your mainly your cyclic GMP mediated. Okay? And this protein kinase G is going to do phosphorylation of this MLCP, that is myosin light chain phosphatase. And we know phosphatase को when we phosphorylate, it's going to become active, and hence it's going to cleave this myosin light chains पे जो भी हमारे phosphorylated groups थे, it's going to cleave that, and that's going to lead to relaxation of the smooth muscles, as we've already discussed. ठीक है, तो blood vessels पे acetylcholine अगर वो endothelium पे act करता है, तो it might lead to vasodilatation, but if the endothelium is mainly disturbed, ठीक है, उस केस में might lead to vasoconstriction by the M3 receptors. ठीक है, and we know because M3 हमारे क्या है, the mainly GQ link type of receptors. ठीक है, all right. And we talk about the GIT as well. It's going to increase the motility, and it's going to increase the secretion, and it's going to decrease the constriction of your sphincters. So increase in gastric emptying, increased peristalsis. ठीक है, and सारे के सारे जो मेरे peristalsis, segmentation, contraction, जो भी हमारे different GI motility के patterns हैं, they're going to get stimulated by the parasympathetic system. ठीक है. What about the urinary system? Urinary system में guys, just remember that urinary system में this parasympathetic supply, what is it going to do is it's going to contract your detrusor muscle. ठीक है, via which receptors? M3. ठीक है, so whatever drug that only acts on M3, I'm going to call it as a vasicoselective drug. मतलब it's going to work only on the bladder. ठीक है, vasico मतलब bladder. तो M3 को contract करके on the detrusor, it's going to lead to detrusor का contraction. ठीक है, and the second thing that it's going to do is it's going to inhibit your internal urethral sphincter. ठीक है, internal urethral sphincter को inhibit करना and M3 के through contraction करना detrusor का, that's mainly your urinary system का जो हमारे पैरासिम्पैथेटिक नर्वस सिस्टम है, इट्स इन्फ्लुएंस ऑन द यूरिनरी सिस्टम, मतलब मेनली वॉइडिंग ऑफ यूरिन हो रहा है. ठीक है, एज वी सी pelvic parasympathetic S2 S3 S4 से mainly we are going to have motor to the detrusor and inhibitory to the internal urethral sphincter. ठीक है, right. And I've already talked to you about कि erection कैसे mediate होता है. Mainly pelvic branching nerves जो हमारी S2 S3 S4, that is the nervi adjuntis, are going to release mainly predominantly acetylcholine, but don't forget we have something known as NANC neurons which are going to release nitric oxide, and that's also going to lead to vasodilatation. ठीक है, right. What about the CNS? Acetylcholine, it's not going to cross the blood-brain barrier. ठीक है, but if it does, if we perform an experiment and if we it is directly injected into the brain, it might lead to arousal, which is followed by depression. ठीक है, now we've discussed acetylcholine as a prototype drug. So in case of pharmacology, you guys, I think you know कि पहले we're going to discuss something known as the prototype drug, और उसके बाद we're going to discuss it mainly कि बाद में कौन-कौन से हमारे different drugs which have better action, better absorption we have developed. प्रोटोटाइप ड्रग दैट इज फॉर ओनली स्टडिंग कि उस ड्रग का एक्शन क्या हो सकता है. वी हैव स्टडीड ऑल ऑफ दैट कि भाई पूरी बॉडी में क्या क्या एक्शन है उसका. नाउ वी आर गोइंग टू टॉक अबाउट द कोलिनर्जिक एगोनिस्ट. नाउ व्हेन आई से कोलिनर्जिक एगोनिस्ट, मतलब दे आर डायरेक्टली एक्टिंग, मतलब दे आर गोइंग टू डायरेक्टली एक्ट ऑन द रिसेप्टर, एंड व्हाटएवर रिसेप्टर दैट वी हैव, मेनली वी हैव द निकोटिन रिसेप्टर एंड वी हैव द मस्कारिन रिसेप्टर, उन पे डायरेक्टली वर्क करना. We'll be studying some other cholinergic drugs which are known as indirectly acting cholinergic drugs. वो क्या करेंगे? They are going to inhibit the metabolism of acetylcholine by your acetylcholine esterase. I'm going to call them anti-acetylcholine esterase drugs. ठीक है, अभी करेंगे. So cholinergic agonists में we have two. We have choline esters and we have alkaloids. Choline esters में we have acetylcholine, we have methacholine, we have carbachol and bethanychol. ठीक है, and in case of alkaloids there is a separate group. We have muscarine, pilocarpine and arocholine. ठीक है. In case of alkaloids, I'm going to only use pilocarpine as a significant drug for us because that is important for us clinically. Okay? Choline esters में we have acetylcholine, methacholine, carbachol, bethanychol. Just remember guys, acetylcholine का कोई action नहीं है pharmacologically speaking. Why? It's not important. And why do we not study it only as a prototype drug? We study it because we don't prescribe it. Why don't we prescribe it? It has an evanescent action. Okay? Evanescent मतलब it's going to be very shortly acting. It has no clinical use. It is a non-specific drug. Okay? And it's going to be rapidly metabolized by your acetylcholine esterase and your butyrylcholine esterase. So it's useless to give it acetylcholine. The second drug in case of your choline esters that we have is your methacholine. Okay?
this methacholine is predominantly going to act on your M2 rather than your M3 receptors. ठीक है, M2 मतलब it's CVS selective. ठीक है, इसका muscarinic action is more than your nicotinic action. So just remember, guys, I'm going to tell you a very important concept. Whenever I'm attaching a methyl group to a choline, okay, just remember, whenever I'm going to attach a methyl group to a choline, the one thing that I'm going to get as a response is it's going to have a better muscarinic action as compared to a nicotinic action. Okay, so whenever I'm going to attach a methyl group to a choline, it's going to have a muscarinic preferential action as compared to a nicotinic action. Okay, methacholine, it's metabolized by acetylcholine esterase. It is not metabolized by pseudocholine esterase. This is important. Acetylcholine was metabolized by a butyrylcholine esterase as well, present in the plasma. But methacholine is only metabolized by acetylcholine esterase. So is it going to be longer acting as acetylcholine? Definitely. It's going to be longer acting than acetylcholine. Methacholine has no therapeutic use, but we are going to use it as a diagnostic use. What is that? In case of asthma, we perform something known as the methacholine challenge test. Okay, I think guys, it will be important for us. Basically what we do is we administer methacholine and we see किस concentration पे the FEV1 is going to drop by 20%. If that concentration is less than 0.8 mg per ml for methacholine, we're going to say it's a positive test. Okay, so that patient might be having this asthma. Again, acetylcholine, methacholine. Methacholine mainly has a muscarinic preferential action as compared to nicotinic action, and it's longer acting than your acetylcholine. Done. The next thing that we have is carbachol. Okay, carbachol में I've now attached a carbamyl group. Okay, by attaching a carbamyl group, what's going to happen is ये जो पहले जो choline था, now it's going to become nicotinic more as compared to your muscarinic action. Okay, and what we achieve by attaching this carbamyl group is now it's going to have a very slow metabolism. But it's not going to be acted by acetylcholine esterase, not going to be acted by a butyrylcholine esterase. So it's the longest acting of them all. Okay, अब इन सबको जोड़ के that is methyl group का muscarinic specific action and carbachol का very long action, दोनों को मैंने जोड़ दिया in this drug known as bethanechol. Bethanechol is going to have both methyl as well as the carbamyl groups. Okay, and it is M3 के लिए more specific. मतलब it's going to be vasicoselective. So this is one drug which I'm going to use now. It's a vasicoselective drug. It's longer acting as compared to any of these drugs, and it has preferential action. Okay. So this bethanechol, what does it do? It's going to increase the contraction of the detrusor. As we saw, detrusor P where the M3 receptors is going to lead to contraction of the detrusor. And why am I using this? I can use it in the following conditions. First is the atonic bladder. Okay. I call it as an overflow incontinence. In this case, the patient does not has an urge to urinate, and basically bladder fills up, and now he's going to have an overflow incontinence. So problem क्या है? Mainly problem is with the tone of the bladder. I need to increase the tone of the bladder. इस करके I'm going to be bethanechol. That's an M3 agonist, selective थोड़ा सा, and it's going to be longer acting as well. So one thing is atonic bladder. Second thing that I can use it is post-operative retention of urine. Okay, that is whether it be a bladder injury or it is due to the general anesthesia use, or it is due to electrolyte imbalance or anxiety or stress, anything. Post-operative retention of urine, I can give this bethanechol. And what are the side effects of all of these drugs? It's going to, but because they're parasympathetic nervous system को activate करेंगे, I might develop colic and diarrhea. Why diarrhea? Because increasing secretions. Why colic? Because I'm going to increase the peristalsis. That might be painful. Okay. Involuntary urination and defecation can develop as a side effect, obviously. Third thing is that patient might develop flushing. We know vasodilation of the skin vessels का हो सकता है, flushing हो सकती है, sweating हो सकती है, as we know कि जो हमारा acetylcholine जो है उसके जो receptors are present on the sweat glands. ठीक है, that's mainly mediated by the sympathetic nervous system. And third is bronchospasm mediated by the M3 receptors. All of these are side effects of bethanechol. What are the contraindications? Because it mediates bronchospasm, I'm not going to use this drug for your bronchial asthma patients or your COPD patients. Okay, so that is bethanechol for you guys. What about the alkaloids? We have discussed the choline esters. उसमें हमने acetylcholine पढ़ा, methacholine पढ़ा, and हमारा mainly हमारा bethanechol पढ़ा. Now we're going to study about alkaloids. ठीक है, जिसमें हमने क्या पढ़े थे? तीन पढ़े थे. Mainly muscarine, pilocarpine पढ़ा, and aracholine. And I told you guys only we need to study pilocarpine because neither muscarine is only important as a mushroom poison. ठीक है, early mushroom poisoning में it is muscarine as the alkaloid. ठीक है, and aracholine is present in betel nuts, but they're not important for us pharmacologically. So what are these drugs known as alkaloids? First thing, they're going to be non-specific in their action, and these alkaloids, as I can say, they're going to be alkaline in nature. Okay, they're not mainly सारे drugs जो हैं, they're mainly acidic in nature, and if they're acidic, they mainly bind to albumin. But these alkaloids or these alkaline जो भी drugs हैं, they're not going to bind to albumin because albumin is itself negatively charged. So it's going to bind to something globulin, that is alpha-1 acid glycoprotein. That's a globulin. Okay, okay. Non-specific action इनका, it's alkaline, and these drugs are lipid soluble. So if these drugs are lipid soluble, can they cross the blood-brain barrier? Definitely. choline esters, that's acetylcholine or bethanical or whatever, सारे के सारे drugs, they were polar. And because they were polar, they were water soluble. And because they're water soluble, they were not able to cross the blood brain barrier, no CNS action. But in case of these drugs, they're going to cross the blood brain barrier. If we deposit them into the cornea as an eye drop, they're going to even cross the cornea as well. ठीक है, तो इनका एक्शन लिपिड सॉल्युबल है, इनके कारण ये काफी स्पेसिफिक है. They're going to be metabolized by the liver. Just remember, guys, any lipid soluble drug that's going to be metabolized by the liver predominantly. Okay? And just remember, alkaloids ये जो हैं, they're going to might release increased amount of histamine from the muscles, and they might have an allergic reaction developing. ये सारे के सारे actions, कोई भी alkaloid आपको मिले ना कभी भी, अभी we are studying pilocarpine, but whatever alkaloid drug is there, these actions are going to be common for them all. Okay? So just remember, so alkaloids are plant derivatives. They're basically derived from your plants. So we're going to talk about this pilocarpine. We know it's lipid soluble, so it might penetrate as the cornea, and if it can penetrate the cornea, we might use it as an eye drop. Okay? And what is it going to do? It's going to stimulate the M3 type of circular muscles of the iris. So that's going to lead to meiosis, and it's going to lead to ciliary muscle as well. Okay? Ciliary muscles could be contract karayega. So why is it used for? As you guys know, we have something known as, guys, angle closure glaucoma. ठीक है, angle closure glaucoma. उसमें problem क्या होती है ना, guys, कि we have something known as the relative pupillary block. ठीक है, so why does this happen usually? I'm just going to tell you. So कोई भी glaucoma का patient, he goes into a low light situation, mainly a movie hall. ठीक है, and what happens is उसकी eye mainly undergoes mydriasis. ठीक है, उसकी eye mainly undergoes mydriasis, and when this mydriasis occurs ना, this your iris, okay, it's going to contact with your with your lens, and that's going to be called as a relative pupillary block. Okay, and when this relative pupillary block occurs, what are we going to have? Now we're going to have the bowing of the iris. So this iris now bows. That's known as iris bombay. Okay, and ultimately, if you see, when this iris is going to bow now, it's going to contact this angle. Why this angle is so important for us? This is known as the iridocorneal angle. Okay, iridocorneal angle. So whenever this iridocorneal, or I can call it as iridotrabeculocorneal angle, whatever. So जब ये angle block होता है ना, यहाँ से हमारे यहाँ पे trabecular meshwork होता है, and that's going to function as mainly your IOP lowering mechanism है हमारा, कि सारा का हमारा जो aqueous हमारे ciliary process से बनता है, travels like this, goes into trabecular meshwork to drain. But what am I saying? कि जब हमारा iris bombay होगा, due to this pupillary block phenomena, what's going to happen is I'm going to have this block of this iridotrabeculocorneal angle. I'm going to see this iridotrabeculocorneal contact, but इसके कारण I might develop precipitation of your angle closure glaucoma. So this is what is happening. What I can do for that? I can give a myotic. So क्या होगा myotic से? ठीक है? First thing is, whenever I'm going to have meiosis now, this जो हमारा जो iris है, it's going to move towards the center. And first thing that it may do is कि जो हमारा जो contact बना है, iridotrabeculocorneal contact, that might get abolished. ठीक है? So now we're going to have better drainage. Second thing that these myotics can do is they're going to even contract the ciliary body. And once they're going to contract the ciliary body, they're going to pull on something known as the scleral spur. और इससे क्या होता है, guys? ये जो trabecular meshwork है ना, it's going to open up. ठीक है? So the trabecular meshwork is going to open up. सारा का सारा aqueous is going to get drained by the trabecular meshwork. So whenever I'm going to do give these drugs known as myotics, इस case में I'm using what? I'm using pilocarpine. ठीक है? So just remember, guys, pilocarpine was a very frequently drug that we used to give in open angle glaucoma. But वहाँ पे अब इसका almost a second, third line drug है. But pilocarpine is still the drug of choice, I would say, for your closed angle glaucoma, because it's very important in case of closed angle glaucoma. In case of open angle glaucoma, it's a PGF2 alpha drug, which are the mainstay. Open angle glaucoma में. But myotics are very important in case of a closed angle glaucoma, and we, as it's seen, guys, ciliary body का contraction is going to pull on the scleral spur, and that's going to increase the trabecular meshwork drainage. And second thing, meiosis के कारण we might lead to widening of the iridocorneal angle as well. ठीक है? And we prevented that. Okay, so this is what I was talking to you guys about. Okay, this is, we have something known as the trabecular meshwork. It's going to empty into the Schlemm's canal, and then we have the outlet channel, the aqueous vein, ultimately into the episcleral vein and your ophthalmic vein. That's how जो हमारा जो हमारा aqueous humor का reabsorption होता है. ठीक है? And where is the aqueous humor secreted from? It mainly is secreted from the ciliary bodies. ठीक है? All right. So this is what I was talking to about. That is, we have something with the primary angle closure glaucoma. और उसके इसमें we can give this. So what are the uses of pilocarpine? Angle closure glaucoma is the drug of choice. We might use it in open angle glaucoma, but it's not recommended. And the third thing we can use it for is Sjogren syndrome. Why? Because Sjogren syndrome, it's an autoimmune attack against your two things, salivary glands and lacrimal glands. ठीक है? So यहाँ पे हमारे salivary secretion भी कम हो जाएंगे, lacrimation भी कम हो जाएगा. Salivary secretion अगर कम होंगे तो obviously I'm going to have xerostomia, difficulty in speaking, difficulty in swallowing. In case of eye में अगर मेरी lacrimation कम हो जाएगा, I'm going to see sandy eyes, gritty eyes. ठीक है? ड्राई आइज मेनली। तो इस केस में जोगरेन सिंड्रोम इज एन ऑटोइम्यून अटैक जिसमें हमारे लाइक्राइनल ग्लैंड्स आर डैमेज एंड योर सलाइवरी ग्लैंड्स आर डैमेज। So what I can do for that? Can I give a congener of your acetylcholine? है ना? This case में pilocarpine will have this muscarinic actions on these glands. It is going to increase the secretion of these glands. I can do that, right? So Sjogren syndrome में it might be used pilocarpine, but then we developed another congener of this pilocarpine that is known as cevimeline. Cevimeline is the preferred drug that we use for Sjogren syndrome. But still, Sjogren syndrome में the problem is these drugs are not altering your what? They're not altering your pathophysiological process. They're not altering the destruction of your glands. So why use them? But in now in Sjogren syndrome that we have is जीरो स्टोमिक के ट्रीट करने के लिए we have sugar free lozenges. ठीक है, तो lozenges है हमारे पास. We don't need these drugs ना. In case you're having gritty eyes, you're having dry eyes, we can have these tear substitutes. So these drugs are not the preferred ones, I would say, in case of Sjogren syndrome, but they can be used. So Sjogren syndrome, we can use pilocarpine, we can use cevimeline. What are the side effects? Because it can lead to meiosis, they might lead to decrease in vision. It might have painful spasm of accommodation. इसके कारण the patient might express brow ache. He might have headache, pain in the eyes. ठीक है? This might because the ciliary muscle is also attached to the retina. और अगर ciliary muscle का बहुत violent अगर contraction हुआ, it might lead to a peripheral retinal detachment as well. ठीक है? And I'm giving this drug as what? I'm giving this drug. I'm depositing into the conjunctival sac. Now it's going to drain into the what? Via the lacis lacrimalis. It's going to drain via the lacrimal puncta into these canaliculi into the nasal lacrimal duct. This is what I'm doing. Okay. But sometimes what can happen is when this drug goes into the nasolacrimal duct में जो भी हमारे smooth muscles हैं, they're going to contract now. And इसके कारण I'm going to have a decrease in the I'm going to decrease the nasolacrimal duct का diameter. That's going to lead to nasolacrimal duct blockage, and that may lead to lacrimation. So that can happen, guys. Okay. All right. So we have discussed one of these drugs. Now the second drugs that we're going to talk about. So अभी हमने क्या discuss किया? Cholinergic agonists. Now we're going to discuss anticholine esterases. We've discussed about the choline esterase enzyme, how it has an anionic site and a static site. Now we're going to discuss anticholine esterases. Okay? So उसमें we have two types of anticholine esterases. We can have irreversible, we can have reversible. So irreversible हमारे Hello guys, so sorry for the interruption. So we were talking about these anticholine esterases and we were talking कि कैसे हमारे irreversible हैं. Why are they so irreversible? They're going to interact with your choline esterase and they're going to form covalent bonding. जो हमारी active sites हैं दो भी, उनके साथ it's going to form a covalent bond. और इसके कारण क्या होगा ना कि if they form a very strong bond like a covalent bond with these sites, acetylcholine can't come and bind to those sites. So if acetylcholine can't come and bind to those sites, acetylcholine का metabolism is prevented. इसके कारण we're going to see an increase in acetylcholine. So do you see, guys? They're indirectly acting cholinergic drugs because they prevent the metabolism of your acetylcholine. So these irreversible drugs, they're going to have formation of a covalent bond with your active site. Okay, we have two classes. We have carbamates and we have organophosphates. So just remember, guys, जो carbamates हैं, they're going to occupy both of these sites. Anionic site को भी occupy करेंगे, static site को भी occupy करेंगे. ठीक है? Just remember, जो हमारे carbamates हैं, they're going to get slowly metabolized by the acetylcholine esterases. But अगर time permits, they might form covalent bonds that I'm talking about, and that process is known as aging. मतलब पहले it's going to have these interactions which are non-covalent, but ultimately जैसे जैसे time जाएगा, we have lose these जो हमारे compounds है, they're going to lose an alkyl group and they're going to undergo a process known as aging, जिसके कारण is going to form a permanent covalent bond. और इसके अब क्या होगा? Basically that enzyme has no function of its own. Now जब तक वो enzyme degrade नहीं हो जाता and we have new enzyme का formation, it's going to function as an irreversible block as we have talked. ठीक है? तो carbamates we have two. We have carbaryl and propaxil. This propaxil is present as a bagon. ठीक है? So all of these are insecticides that we use. ठीक है? Organophosphates very important for your agricultural work में. Organophosphates are only going to occupy the static site. Are they going to interact with the anionic site? No, not at all. ठीक है? This is going to be very important for a pharmacologically because we have these antidotes, ठीक है, which are known as oximes. So these oximes are going to interact with the anionic site, all right? But if the organophosphates are only binding to the static site, is the anionic site free? Definitely. Can oximes bind to the anionic site? Definitely. Can they prevent this interaction of your organophosphates with the cholinesterase enzyme? Definitely they can do it. But अगर मैं same question आपसे पूछूं कि अगर carbamates हैं, because carbamates are interacting with both the anionic site as well as the static site, क्या oximes bind कर पाएंगे anionic site पे? They can't. So can we use carbamate? Can we use oximes in case of carbamate poisoning? No, we can't. So carbamate poisoning में the oximes are contraindicated. ठीक है, I will talk about this why they're contraindicated. मतलब दे भी तो सकते हैं, but we're going to see why they're contraindicated. ठीक है, so these organophosphates, they have more chances of your covalent bond formation as compared to your carbamates. And what are they? We have malathion, parathion, and we have these nerve gases. ठीक है, chemical warfare में use करते थे. That is sarin, soman, and your tabun. ठीक है, so these are the organophosphates. All right. So this guys we know कि हमारे anionic side पे हमारा glutamate present है and हमारे esteric side पे हमारा serine present है. And this is how the acetylcholine molecule was getting hydrolyzed. जो हमारा ester bond था यहाँ पे, ये जो हमारा ester bond है, ये वो break हो रहा था. ठीक है. And this is what I am talking to you guys about. ये हमारा अगर एंजाइम है ना, वी माइट हैव इरिवर्सिबल इनहिबिशन और वो एजिंग हो सकती है. एजिंग क्यों हो रही है वो? बिकॉज व्हेन आई मेक दिस आर ग्रुप गाइस, आई नो दैट यू नो दैट इट्स एन अल्काइल ग्रुप. ठीक है, सो व्हेनेवर दिस organophosphates or carbamates irreversible वाले, when they're going to lose an alkyl group, mind you, they're going to become what? They're going to become aged. अब वो कुछ नहीं तोड़ सकते तुम उनका बहुत परमानेंट वहां पे बॉन्ड बन गया है. इट्स अ फॉस्फेट बॉन्ड, इट्स गोइंग टू बी अ वेरी स्ट्रॉन्ग बॉन्ड, नॉट गोइंग टू ब्रेक. तो कोवलेंट बॉन्ड बन गया यहाँ पे. ठीक है, सो ये कोवलेंट बॉन्ड क्यों बना? विद टाइम दे गोइंग टू लूज दिस अल्काइल ग्रुप. सो एनीथिंग दैट आई कैन डू फॉर रीअल्काइलेशन, फिर उसके कारण दे माइट बी यू आर नॉट गोइंग टू फॉर्म अ कोवलेंट बॉन्ड फॉर्मेशन. ठीक है जी. So now let's talk about this organophosphate poisonings and what are the effects that we could have. The effects are similar to your acetylcholine. So let's just see. They're going to lead to a decrease in blood pressure. You know why? Because they're going to mediate vasodilation via the endothelial derived relaxing factor. We talked about this endothelium. They're going to lead to bradycardia, which receptor M2. They might lead cardiac arrhythmias as well. They might lead to cardiac arrhythmias. They might lead to colic via M3 receptors. We talked about this. They might lead to involuntary defecation and urination again via M3 receptors. They're going to lead to increase in secretions, like increase in lacrimation, sweating, salivation. We've talked about this. Why they're going to lead to blurring of vision? Due to the meiosis or due to strong accommodation का spasm. They might lead to bronchospasm again via M3. And अगर इनके CNS actions हैं, ठीक है, so they might lead to tremor, ataxia, coma, and death. And the patient might ultimately have respiratory failure, because this is what is happening. All right. So you can remember it as a mnemonic as well. So the mnemonic that we have, muscarinic actions के लिए the mnemonic is sludge. So what is the sludge? Salivation, lacrimation, urination, defecation, GI cramps, and emesis. So this is sludge. When we talk about the nicotinic actions, so what are they? I can remember it as MTF. Okay? MTF. So what are they? That is muscle weakness is there. There is twitching and there is fasciculations. Okay? So these are the nicotinic actions. Why their weakness? Because whenever I'm going to, what's going to happen is, जब हमारा बहुत सारा amount of acetylcholine is going to get released, है ना, मतलब बहुत सारा हमारा acetylcholine is going to build up because हमारे acetylcholine esterase enzyme जो है inhibit हो गए. So this acetylcholine is going to continually work on the post-junctional membrane, that's your muscle end plate. और ultimately क्या होगा ना, the muscle end plate is going to downregulate its receptor. Due to this downregulation of receptors, we're going to have muscle weakness. तो पहले में twitching and fasciculations होगा. Ultimately, we're going to have muscle weakness. Ultimately, the patient might have respiratory failure as well due to this intercostal muscles का weakness as well and due to CNS action as well. ठीक है? How do we diagnose this organophosphate poisoning? Obviously, we can diagnose it on a clinical basis. If you want to perform a laboratory investigation, I might look at the pseudocholinesterase enzymes as well. Okay? Pseudocholinesterase levels I can see because they're more sensitive to these poisons. I can measure them very easily present in the plasma. Okay? So pseudocholinesterase levels. So what are the treatment? Mainly the treatment that we give is atropine. So what is atropine? Atropine is a muscarinic blocker. ठीक है, इट्स अ मस्करेनिक ब्लॉकर एज वेल एज मतलब जो मेनली एट्रोपिन जो है सारे के सारे जो हमारे मस्करेनिक इफेक्ट्स हैं इट्स गोइंग टू टेक केयर ऑफ दैट. तो एट्रोपिन वी गोइंग टू सी हाउ मच आर वी गोइंग टू गिव. वी गोइंग टू गिव 2 मिलीग्राम आईवी हाई डोज एट्रोपिन हम दे रहे हैं एवरी 10 minutes till we see atropinization. What is the best indicator of your atropinization is your drying of the secretions. That is the most sensitive, I would say. Then, followed by that, we can see bilateral chest clearance as well due to decrease in tracheobronchial secretions. Heart rate becoming more than 70, that's also one sign. Mydriasis, very less specific, and your systolic blood pressure becoming more than 100. So, all of these signs are your signs of atropinization, but the best among them all is your dryness of the secretions. Okay? Atropine is not going to reverse your peripheral muscular paralysis. Okay, mind you. And atropine आपने दिया 2 milligram every 10 minutes till atropinization, then you're going to give them maintenance dose till your 1 to 2 weeks or even more than that. Okay? What about oximes? I told you guys कि oximes जो हैं they're going to bind with the anionic side. Okay? Because the anionic side is already bound due to the carbamate poisoning, we're not going to use them in carbamates. We're going to use predominantly in OP compounds का poisoning. Okay? So why are they contraindicated in carbamates? Because these oximes are binding to the anionic side. You understand? If they're going to bind to the anionic side, are they not going to inhibit the metabolism of acetylcholine further? Definitely they're going to do that. तो अगर कार्बमेट पॉइजनिंग है और ऊपर से आप और ऑक्साइम्स दे रहे हो, जो भी हमारा एसिटिलकोलिन एस्टरेज बच भी गया है ना, उसे भी आपने इनहिबिट कर दिया वाया दीस ऑक्साइड्स. मतलब दे हैव अ anticholinesterase enzyme का effect on their own as well. But because OP compounds are irreversible and we don't want this aging to happen, we might give oximes in case of organophosphate poisoning. But because organophosphates के case में, they're not going to bind to the anionic side. They're only going to bind to the esteric side. Hence, we can use oximes. Okay? So the oxime that we use is, we can use PAM. That is one thing that we can do. That is pralidoxime. The second oxime that we have is obidoxime. And the third one, which is not available here, is diacetyl monoxime. That is DAM. Okay? So this pralidoxime की problem ये है, this pralidoxime has a quaternary nitrogen. So if this is going to be a quaternary nitrogen, it's basically polar. मतलब it's not going to cross the blood-brain barrier. तो कोई भी CNS effects है ना of these carbamate poisoning, ये oximes are not going to do anything about that. ठीक है? उस केस में क्या यूज करेंगे हम? एट्रोपिन. एट्रोपिन इज गोइंग टू योर बेसिकली because it's going to cross the blood-brain barrier very easily. Okay, so contraindications क्या oximes की? It's mainly carbamate because oximes themselves have weak anticholinesterase activity on their own. How are we going to give it? We're going to give it 3 milligram per kg IV loading dose, and then we're going to continue it as a slow infusion by 8 to 10 milligram per kg per hour slow infusion. Okay, they're going not to penetrate the CNS. Mainly CNS के केस में pralidoxime is not going to do that. उसके लिए we can use diacetyl monoxime, that is DAM. ठीक है. Then third thing that we can do, for obviously we're going to maintain the airway, breathing and circulation as well, and decontamination is very important. That is, जो भी contact आया है basically organophosphates का, we are going to remove the clothes and we are going to perform a gastric lavage. ठीक है? emesis however is contraindicated in case of your organophosphate poisoning. So this was something about that. Now the second group of enzyme that we have is reversible anticholinesterase inhibitors. Okay? So reversible anticholinesterase inhibitors, mainly why they're reversible? Because they're going to form an ionic bond. They're not going to form a covalent bond over here. Okay? So इस पे भी we have two types. We can have carbamates, we can have non-carbamates. Organophosphates की तो बात ही छोड़ दो, because organophosphates are going to form a covalent bond. ठीक है? तो we're not going to discuss them in reversible. But carbamates might form a reversible anticholinesterase activity भी उनकी हो सकती है. So we can have carbamates or we can have non-carbamates which have a carbamate-like action. Carbamates में कौन कौन से हैं? We have physostigmine, neostigmine, pyridostigmine and rivastigmine. ठीक है? Just like carbamates, they're going to occupy the anionic and the static side both. ठीक है? And in case of non-carbamates, we're going to have these drugs which are tacrine, donepezil, edrophonium and galantamine. ठीक है, ये हमारे non-carbamates हैं. But इनके special बात क्या है? They're going to only attach to the anionic side. So we have organophosphorus compound which only attach to the esteric side. We have carbamate compounds which are going to interact with anionic as well as esteric side. And now we are seeing we have non-carbamates like reversible anticholinesterase inhibitors which are only going to attach to the anionic side. So these are tacrine, donepezil, edrophonium and your galantamine. We're going to see them. Okay? Alright. So let's see. Now we are going to divide this further. ये जो drugs हैं anticholinesterase, we can divide them into tertiary amines and quaternary amines. ठीक है? Why am I going to divide that? Because tertiary amines are going to be non-polar. As you see, nitrogen पे कोई भी अगर charge नहीं होगा, it's going to be non-polar. If they're non-polar, they're going to be lipid soluble. And if they're lipid soluble, these tertiary amines, they're going to cross the blood-brain barrier, and they can even cross the cornea as well. They're going to metabolize by the liver, just like alkaloids. So ये जो सारी properties हैं, they're going to have similar properties like alkaloids. And they're going to have a better absorption as well, because GI mucosa bhi kya hai? It's going to be a lipid membrane only, है ना? What about the quaternary amines? Because they have a positive charge over here, they're going to be polar, they're going to be water soluble, they cannot cross the CNS, they can't be used as an eye drop, and they're mainly eliminated by the kidney and not by the liver cells. And they're going to have a poor oral absorption. So we have quaternary amines, we're going to have tertiary amines. Let's discuss pehle tertiary amines. Tertiary amines में the first one that I'm going to tell you is donepezil. So तीन है हमारे पास, donepezil, rivastigmine and galantamine. ठीक है? What are they going to do? They're going to inhibit the cholinesterase enzyme. What are they going to do? Mainly acetylcholine increase करेगा. And because they're tertiary, they're going to cross the blood-brain barrier as well. True. If they're going to cross the blood-brain barrier, can I use it in a condition जहाँ पे हमारे acetylcholine कम हो and CNS condition में? So one thing that I'm going to tell you is कि Alzheimer's dementia or any kind of dementia, we can use these tertiary amines, mainly donepezil, rivastigmine and galantamine. Preferred of them all is mainly your donepezil. ठीक है? Because dementia में क्या होता है, especially in case of Alzheimer's dementia, I would say. So this is, I would say, just revise it on your own. Physiology में we have something called the Papil circuit. ठीक है? Papil circuit is वैसे थोड़ा arbitrary, but I just wanted to tell you guys, Papil circuit में component is known as your basal nucleus of minor. ठीक है? So this basal nucleus of minor is mainly your acetylcholine वाले neurons. Alzheimer's dementia में, due to the neurofibrillary tangles and your beta amyloid plaque, ये basal nucleus of minor is the one which is going to degenerate. इसके कारण we're going to have a decrease in acetylcholine पूरे CNS में. ठीक है? तो why these drugs? They're going to inhibit the cholinesterase present in the gray matter. That's going to increase the amount of acetylcholine, and I'm going to have better cognition in these patients. Are they going to inhibit the progression of the disease? No, they can't. But basically, they can function to ameliorate the symptoms. Okay? So donepezil, galantamine, and rivastigmine can be used for Alzheimer's dementia. That's for sure. ठीक है, done. Any kind of dementia we can use them. What about the next drug? We have the next drug that is physostigmine. Okay, physostigmine. It's again a tertiary amine. Okay, physostigmine. So this physostigmine का main action is they can, because it's a tertiary amine, it can cross the blood-brain barrier. Okay, it's going to cross that blood-brain barrier. I'm going to use it for atropine and belladonna poisoning. Why can't it use quaternary amines in case of that? Because quaternary amines cannot cross the blood-brain barrier. अगर मैं neostigmine use करूंगा atropine या belladonna poisoning में, is not going to cross the blood-brain barrier. I'm not going to have CNS symptoms में जो भी हमारे delirium वाले जो symptoms हैं वो treat नहीं होंगे. Physostigmine on the other hand, because it's a tertiary amine, it's a lipid soluble, can cross the blood-brain barrier, and hence that is the reason why I'm going to use it in atropine and belladonna poisoning. What other things? I'm also going to use physostigmine, ठीक है, as a miotic as well. ठीक है, in case of glaucoma, I'm going to use it as a miotic as well. तो दो drugs हो गए, pyrocarpine as well as physostigmine. ठीक है, right. Now we're going to move on to your quaternary amines. Quaternary amines की हमने properties हमने already पढ़ ली है, and they're going to mainly work on peripherally. They're not going to cross the blood-brain barrier. ठीक है, and what are they going to do? अगर वो NM receptors पे work करेंगे, they're going to increase the strength of the voluntary muscle, and they can have some muscarinic effects as well. तो यहाँ पे हमारे पास तीन है. Let's compare them. We have pyridostigmine, we have neostigmine, and we have edrophonium. The longest of सबसे ज़्यादा longest working जो है that is your pyridostigmine, and सबसे ज़्यादा shortest working जो है that is your edrophonium. ठीक है, and why are we using these drugs? हमें क्या करना है? Strength of voluntary muscle increase करना है. So what is that condition जहाँ पे हमारा strength of voluntary muscle is impaired? That's mainly your myasthenia gravis. ठीक है, myasthenia gravis में, because it's an autoimmune response against your nicotinic acetylcholine receptor present on the muscles. ठीक है, due to maybe a thymoma, 20% cases में it might be a thymoma. So myasthenia gravis is an autoimmune condition. उस case में I'm going to have muscle weakness. So what am I going to do is I'm going to increase the acetylcholine that's going to work on these some amount of receptors which are present over there, and that might lead to an increase in your muscle contraction. Pyridostigmine, because it's the longest acting one, अगर मैं myasthenia gravis में use करता हूँ, I can use it at a maintenance. But problem ये है pyridostigmine की that it's slow in onset. So अगर I'm going to see a myasthenic crisis, it's sudden onset of weakness, acute emergency में, I'm not going to use pyridostigmine. What am I going to use in that case? I'm going to use a neostigmine. Okay, neostigmine has a faster onset, but problem ये है, it can be used as a maintenance as well, but pyridostigmine is preferred. So I'm going to use neostigmine in case of an acute emergency. And what about edrophonium, you might be thinking? Because it's a very short action, it's very few minutes, it's only used in case of diagnosis of myasthenia gravis. Okay, and what is the diagnosis? And you know guys, edrophonium is only going to bind to the anionic site. Okay, don't forget that is your tacrine, donepezil, and your edrophonium is only going to be bind to the anionic site. It's a non-carbamate drug. Okay, so what is this edrophonium test that I'm going to use for myasthenia gravis? It's also known as the tensilon test. क्या है? Myasthenia gravis में we give 2 milligram IV test dose में we give your this thing, that is your edrophonium. If you don't see any reaction to it, everything goes well, we're going to inject the rest amount of 8 milligram IV of your edrophonium. And now what I'm going to see in that patient of myasthenia gravis is there's going to be substantial improvement in weakness, ptosis, diplopia within 30 seconds. And this effect is going to last up to 5 minutes. So this is known as the edrophonium test. Why am I saying this, guys, कि 2 milligram IV test दे रहा हूँ? Because कोलिनर्जिक अगर टॉक्सिसिटी होती है ना, एज वी सॉ अभी हमने ऑर्गेनोफॉस्फेट पॉइजनिंग पढ़ा, उसमें हमने पढ़ा कि उसमें भी वीकनेस होती है, एंड यहाँ पे भी वीकनेस हो रही है माइस्थेनिक ग्रेविस में. हाउ कैन आई डिफरेंशिएट बिटवीन माइस्थेनिक वीकनेस एंड योर कोलिनर्जिक वीकनेसेस? आई एम गोइंग टू गिव एड्रोफोनियम. अगर वो 2 मिलीग्राम आईवी टेस्ट डोज ऑफ एड्रोफोनियम में पेशेंट डिटीरियोरेट कर गया, देन दैट मींस इट्स अ कोलिनर्जिक क्राइसिस. मतलब एसिटाइलकोलिन ऑलरेडी ज्यादा था, आपने एड्रोफोनियम देके और बढ़ा दिया और वो पेशेंट सफर कर गया. But in case that weakness is going to improve, I'm going to inject 8 milligram IV again and see the full course of action, and then I'm going to make a diagnosis. यार ये cholinergic weakness नहीं है, this is going to be a myasthenic weakness. So what are the different what are we can use them for? We can use them in myasthenia gravis. We can use it in Lambert-Eaton myasthenic syndrome as well. The third thing that we can use these drugs is mainly your quaternary amines, is mainly for your cobra bite poisoning, because cobra bite may be we have some conotoxins which are present over there that's going to work at the NM receptor only. Okay, cobra bite may, as you might know, cobra belongs to the Elapidae family, and the first thing that we clinically see जो हमारी first sign that's ptosis. Okay, and that happens due to muscular weakness. Cobra poisoning maybe we can use your these drugs, pyridostigmine, neostigmine. Okay, and we can also use them for reversal of your skeletal muscle relaxant like succinylcholine post-operatively, and for post-operative retention of urine and ileus के लिए भी we can use these drugs as well. Okay, and we know we're not going to discuss dementia today. So basically, I told you about the myasthenia gravis as well, and how can we use the edrophonium as a diagnostic test. That is for your tensilon test. The second test that we use for myasthenia gravis mainly is your something known as your serology. can we check for anticholinesterase receptor, anti-acetylcholine receptors जो हमारे NM type of receptors के against antibodies we can check, and anti-musk antibodies we can check. ठीक है, hydrophonium test we can perform, that's known as the tensilon test. We can also perform the same test with neostigmine and pyridostigmine as well, तो उसका नाम उस पे है. And we also have an ice pick test over here. Ice pick test में ये है कि whenever we decrease the temperature by applying a ice pack over your eyes, तो जब वो टेम्परेचर कम होएगा, दैट्स गोइंग टू डिक्रीज द एक्टिविटी ऑफ योर एसिटाइलकोलिन एस्ट्रेस एंजाइम, तो उसके कारण एसिटाइलकोलिन इज गोइंग टू बिल्ड अप. और अगर एसिटाइलकोलिन अगर थोड़ा बढ़ जाएगा, तो इट्स गोइंग टू वर्क ऑन द रिमेनिंग रिसेप्टर्स एंड दैट्स गोइंग टू इंक्रीज योर आई ओपनिंग. ठीक है, तो पैल्पेब्रल फिशर का अगर इंक्रीज कर गया डायमीटर, वर्टिकल डायमीटर बाय 2 मिलीमीटर्स, देन आई वुड से कि माइसिना के लिए इट माइट बी पॉसिबल. ठीक है, EMG में इलेक्ट्रोमायोग्राम में वेरी इंपॉर्टेंट थिंग इज आई एम गोइंग टू सी अ डेक्रीमेंटल रिस्पॉन्स फॉर योर माइसिना ग्रेविस, एंड दिस इज गोइंग टू बी different in case of your Lambert-Eaton myasthenic syndrome में. वहां पे I'm going to see an increase in the response. ठीक है, तो what I'm going to do is I'm going to perform a repetitive nerve stimulation study. ठीक है, जैसे जैसे repetitive मैं उसे stimulus दूंगा, repetitive nerve stimulus दूंगा, यहाँ पे I'm going to see a decremental response in case of myasthenia gravis, and I'm going to see an incremental response in case of your LEMS. ठीक है, that's important. ठीक है, so we discussed about that. And now, the last drugs that I'm going to talk to you about is the anticholinergic drugs. They're also known as your muscarinic receptor antagonists. ठीक है, anticholinergic मैं इसके लिए कह रहा हूँ because they are also known as the ganglion receptor blocks. Alright, I think guys आज के लिए I think we have done about 50 slides. So आज I think I'm going to stop right now. So आज we've discussed your because आज we had 2 chapters here. That is your general consideration of your ANS and your cholinergic drugs. Kal we are going to discuss your anticholinergic drugs and your sympathetic and your maybe your that is your sympathomimetic drugs as well as your sympatholytic drugs. Okay, so I'm going to close this session today. Actually, I wanted to discuss the anticholinergic drugs as well because I think thoda sa late ho gaya. Kal we're going to start at an earlier time. We might start at 9:30 because kal thoda zyada ho jayega, and we're going to finish it in 1.5 hours. Okay, so आज you've done I think quite a bit. I've tried to cover all of the points that are there in the book. So आज we have done ANS general considerations as we have also done the cholinergic system as well. Anticholinergic drugs जो भी हमारे mainly we need to study atropine and some of these synthetic derivatives. ठीक है, that is your mydriatics or vasoselective drugs or anti-Parkinsonian drugs. हम सब कल discuss करेंगे. ठीक है. So I hope you like this session, right? So we're going to meet tomorrow at an earlier time. I'm going to tell you the time, 9:30 maybe. We can start at 9:30 and we'll be finished by 11. I'm going to take some amount of time. I'm going to start the session earlier कि हमारा पूरा cover हो जाए. Because obviously it takes a lot of time, you know, like पूरा 1 hour is a little bit less I would say, and 2 hours for ANS is like very less I would say. So in case you're doing it for the first time as well, I want to give you an thoda sa integrated portion as well. If I'm discussing about myasthenia gravis, if you don't know about myasthenia gravis से थोड़े से उसके diagnostic features ना, तो थोड़ा if you know that, तो it's going to make a lot of difference. ठीक है, myasthenia gravis obviously comes as a short note as well. Management of myasthenia gravis can also come. ठीक है, or your management of your OP poisoning can also come. तो उसके लिए we need to go into some amount of detail as well. ठीक है. All right, I hope you like the session. So I'm going to close the session right now. If you have any questions, you can reach out to us at our Telegram group. You can message me directly. You can message on our Instagram channel as well. You can message over here as well at the live chat. Please feel free. So if you like this session, please give me a thumbs up in the chat and I can see how many people attended actually. And in case even if you fail to attend that or if the timing doesn't suit you, all of these sessions are being stored. We've already completed physiology, and by maybe 7 to 10 days, I think about 10 days I would say, 10 days we'll be covering the main units of your pharmacology. Okay, the main हमारी units है, that's your ANS or your CVS, endocrine. Then we have the chemotherapeutic drugs and जो भी anti-cancer drugs and your general portion as well. Some bits about blood as well as nerve muscle as well. जो भी हमारे main units हैं, we're going to cover those only in case of your pharmacology. Some of these units we might be skipping over them, but जो हमारे main unit wise जो बड़ी units हैं जिसमें problem आती है, we're going to cover that. And ANS is one of those portions which is going to be very frequently asked to you as well, whether it is about be the prototype drug of your parasympathetic system that is your mainly your acetylcholine, uske actions on the body, or the different choline esters or your different alkaloids, and the thing about pilocarpine, how it can be used in closed angle glaucoma, how does it prevent the iridotrabeculocorneal contact. All of these questions can be asked in a Viva as well. कि why do we use pilocarpine in closed angle glaucoma? उस केस में थोड़ा सा ophthalmology का integration is very important. And I think it would make sense कि अगर हम वो अभी भी साथ के साथ अगर हम वो करते जाए. It takes a lot of time, I know, but it makes a lot of sense doing that way. Okay, I'm going to close this session right now. So I thank you all for watching, and I'm going to see you tomorrow at the same time, maybe earlier than that, 9:30. Thank you so much.